Um, Rob Stansberry, pulmonary critical care, sleep medicine at WVU. So are you guys seeing the correct screen or do I need to switch it?
No, we see the correct screen.
Okay.
Thank you.
Wait a minute.
So
No, I'm not sure this is the correct screen because this says, I thought we were doing ATS, best of ATS.
I switched it up on everybody.
Oh, okay.
Yeah, because
Okay.
so we got some funding for a project that we're hoping to roll out to some of our rural clinics. Dr. Doyle, you should be familiar with this.
Yes.
So I was hoping actually to get some feedback from some folks. Looks like I picked the wrong day, but um, maybe some people can at least listen to the slides and give some feedback. But this is the West Virginia Obstructive Sleep Apnea Academic Mentoring Partnership, which I know is a lot of kind of wordy, but it's a program that we hope to be initiating soon. And like I said, my plan today was really to present the program and then kind of go over why it's important, what's the structure of the program. Then I was hoping to get some feedback from some of our folks who typically attend this call, but maybe they can email me some feedback at some point. So
Hey,
when you
Rob,
look,
can ask you something? Who else besides Cabin Creek and New River?
I mean, anyone, I mean, even Allison,
Allison, who's that?
Sheila, she's a pulmonologist
Oh,
at
okay,
Preston
yeah,
County.
yeah,
Yeah.
yeah. Okay, so those are
But
some of
even
the,
RTs who are typically on, I think it would be helpful for them.
okay, because I'll text Krista and Lisa and remind them right now. I mean, I'm hopeful that some other people will jump on.
Okay. Um, so when you look at the prevalence of sort of short sleep, and when you look at short sleep, particularly once you get below that 6 to 5 hour, um, average sleep time, um, you really start seeing some health consequences from that. And when you look at Appalachia here, there is really I mean, it's really impressive. It's almost like the obesity maps, how bad sleep is in Appalachia. And I've really tried to figure out what drives this. Some folks have noted that a lot of people work multiple jobs or do shift work. A social worker suggested that as a potential problem. So maybe that's a potential driver of this, short sleep. But
Can I ask
it's
can I ask a question
short.
about that slide?
Mhm.
How sure are you that that is close to true?
Yeah, I mean, this is from the CDC's behavioral risk factor surveillance system. So that is based on phone calls reported,
Right.
self-reported. So maybe Appalachia for whatever reason, reports inaccurately compared to the rest of the country.
Yeah, so I mean, because it's so stark,
I
and
mean, it's really right.
yeah, and it's so much parallels a bunch of other clusters of disease that we know about. You know, we see this on all kinds of slides, and you kind of have to wonder: is this the epidemiologic biologic truth? And I guess it's a stab at it, and it's the best we've got.
Right.
Yeah, that's the best we have. I mean, it's BRFSS is done at the state level. You know, state public health departments are funded to do it, and it is phone call based with the issues associated with that. But it's the best we've got.
And so there's a lot. Oh,
You
sorry.
raised your hand. Did you have a question or comment?
Dan, I suspect that it may be a valid representation of obstructive sleep apnea, since it really so closely follows both the COPD prevalence map as well as the use of tobacco.
As
So,
well, and
This
all,
isn't sleep apnea. This is short sleep duration.
yeah, short sleep duration. it seems to follow along those trends, with Appalachia being outstanding in multiple areas that are not good for public health.
Yeah, it's also obesity.
Yep.
Those obesity, I think, measures.
Well, and people working multiple jobs. I mean, when you're working a minimum wage job and you're supporting a family, you wind up working a lot more hours. So lot of challenges here.
Yeah.
And sleep has really made it into sort of the mainstream press recently. And people talk about the pillars of health being, diet, exercise, and sleep. But sleep has really been ignored for a while. But there's a lot of societies now. This is from the American Heart Association, who's last year added sleep as one of life's essential 8 for cardiovascular health. And I think part of what's driven it is all the wearables now that track sleep. It's really just bringing it into the public eye. And then we've mentioned the obesity epidemic multiple times in West Virginia. And as I've shared when I've talked about sleep apnea in the past, why is it this important for West Virginia? And it's really these, multiple other comorbidities, in particular COPD and cardiovascular disease. And, sleep apnea has been shown, at least based in the epidemiologic studies, to really sort of impact the outcomes in these two disease processes. And this is a slide I stole from the West Virginia Rural Health Association's a presentation last year on really intervening at the community level, and where you intervene really matters. And so often in healthcare, I feel like we intervene downstream where the patient already has established disease, and we're just trying to do the best we can to sort of manage them. But early on, I actually did work in COPD trying to improve outcomes. And we partnered with Philips to try and develop this respiratory coach and optimize any NIV therapy these patients were had. But I think we got them to maybe use their inhaler a little bit more and increase their use of NIV by like 10 minutes, with a huge amount of support, and outcomes were still terrible. We actually had a very high mortality rate in both arms, and a lot of hospitalizations in both arms. And I think you can say the same with heart failure. I mean, really, even when you have specialists involved, it's a it's a downward course. We don't really have a huge impact on the ultimate outcome when you look at sort of broad data. Dan?
Yeah, so I remember you used this slide before, and it does seem like a really important slide that applies to all kinds of things.
Mm-hmm.
And this is exactly where we are in the Appalachian Pulmonary Health Project, with starting out with pulmonary rehab, which is really trying to provide something to people with advanced, moderate or severe, so advanced lung disease. But we're also doing vaping prevention in middle schools to try to work with youth and children that they don't get addicted in the first place. So that's, we're up there at the top with the vaping project, and we're down there at the bottom downstream with pulmonary rehab. And we all agree we're not going to give up on the people downstream. That's a lot what we do. We're going to take care of them. But we see that so much of what we're dealing with is preventable. And so I think it's a great slide to apply to many issues.
So you're up here in the upstream. Now, what I feel like, we are sort of going to improve. We're more midstream when we're working on someone's sleep, as opposed to downstream, like the work we've done in the, in the past, or sort of advanced COPD care pathway. So,
But you're going to keep doing that, that's part of what
but I,
fellows are learning. But it's showing them this also gets them to think about there's more than the ICU and the procedures.
that's a really interesting point, Dan. I'm glad you brought that up because, I'm part of a vaccine initiative from ATS, to really sort of focus on how we improve vaccinating high-risk individuals. And part of the struggle we had, and we're actually trying to put a paper together on this, is so many pulmonologists go into, pulmonary and critical care for like acute illness in the ICU. And, preventative care is not what gets them interested in pulmonary. So, part of this initiative is really sort of getting the pulmonary and critical care committee or community thinking about preventative pulmonary medicine.
Great.
That's an.
And I think people burn out if all they're doing is critical. I mean, with my little bit of personal experience with it, I think that critical care, we need it. It's so important, but to me, it's also an area of, a lot of psychological stress and potential for burnout. So having that balance of doing that, but having something else like the vaccine initiative or preventive care, to me seems like a healthier mix of practice.
David, did you have your hand up?
Yeah, I mean, I was just going to say, I mean, there are a lot of analogous things like wearing seatbelts, right? I mean, so you were talking about, teaching kids about vaping, and one of the biggest things for seatbelts was teaching kids to chew on their parents to wear their seatbelts, way back when, and teaching kids to chew on their parents about smoking is another thing, and the whole public health thing is very underfunded, right? As we all know. And in the post-pandemic era, it's public health departments have come under huge pressure, and I think we've got a lot to overcome.
So I think I've shared this slide with you guys before, but this is some of the work we've done in this area. Under recognition, or at least under coding of diagnoses for these different conditions, with sleep apnea potentially being under recognized in our communities. And then this was a study where we went out into the communities and actually gave we did semi-structured interviews with rural providers just to get a better understanding of their thoughts on obstructive sleep apnea. But then we also gave them the Osaka questionnaire, which is a validated knowledge and belief questionnaire regarding sleep apnea. And it was sort of interesting findings. Everyone thought it was important as a disorder and important to diagnose, but really had low confidence in identifying or managing sleep apnea, at least what they reported. Now, what was sort of interesting is on the knowledge questionnaire they completed, except for a few questions, they actually did quite well. So it was sort of interesting findings. And then, as I mentioned, we did do, focus groups with these folks. And the CFER is a implementation science map to really kind of tease out what are the barriers and facilitators to care in a given area. And you can kind of map the themes you identify with in your semi-structured interviews with to these different domains, and then it gives you a idea of where you might intervene when you're designing a program. Dan?
Yeah, in your research team, who brought this to the table?
Nicole Stout.
She the School of Public Health with Adam? Or who is she?
She's in the Cancer Center, but she is a phenomenal implementation scientist.
Okay, great. Yeah, it's because to me, when I see this and I think Rob Stansbury, critical care position, but it's part of a team and people. So we're interested in the research all of us too. And so it's interesting to know who's on your team. And I saw who your authors were for this article. So great. That's interesting. Thanks.
And I should mention Tony Rudisil, who was second on this. She's in the School of Public Health, and she is a phenomenal sort of mixed methods researcher. She does a lot of sort of public health work and research and program evaluations. And actually, I think right now she's studying the effects of marijuana on driving using a driving simulator. So
great.
So this is kind of how we're planning on doing this. This is not set in stone, but this is, this is based on Dr. Feinberg's work in hepatitis C and the hepatitis C academic mentoring partnership, where she actually trains, primary care providers to cure hep C. Now, she does a full day course. When we were initially going through this, we thought the training could actually be done in a half day. And this is our initial outline for the half day of training. I think we've already talked about like moving the break a little later, and we might play with this a little bit more, but this is sort of the structure we were developing. We were going to have, different folks come in and give these talks. And then the way this works is, the providers we recruit would have a half day of training, this sort of lecture series. And then there's a REDCap database, and part of this training is on utilizing the REDCap for the sleep apnea program. And we use REDCap as kind of a consultant with experts at the university to support providers in these rural communities, to help with, one thing we found all the time, one big complaint was, a sleep provider will order a sleep test and it'll say there's sleep apnea, but then it'll give all these different, and one problem is they get just this 1-page report that they can barely read sometimes. And then it doesn't give any definitive recommendations based on the patient. So when the primary care provider orders the sleep test, they can actually put it into REDCap so we can review it. And then we can sort of message back and forth kind of asynchronously on, things to consider for treatment. And then, if the primary care provider decides to pursue treatment, we're available for consultation. We can help support any troubles they may have with CPAP or getting referral to a surgeon or whatever problems they may have. And then, ideally, we'll also be able to follow their CPAP usage and look at their data from their machine. And then if there are concerns or questions or consults that come up throughout the care, we're available for consults back and forth. And like I said, this is based on Dr. Feinberg's model, which has been very successful for hepatitis C.
I got a question about, so again, this is really fascinating because you're creating a system here, which completely goes along with the whole echo idea. But Grace Ann, this really reminds me of Capgate for pulmonary rehab, for our pulmonary rehab network, except the Capgate tends to be one way, just to create a register, whereas this is interactive. If it works, and ideally, this would be interactive and go back and forth. So, we have, this is another one we could spend a long time on. It looks like a great system, but it'll depend on how fast things move. It depends on a lot of things, but I think it's a great model, and we have worked with this kind of system with Capgate and pulmonary rehab.
Yeah, and I think to your point, that's what Judith said. The most important thing is timely responsiveness to the providers. So she's actually had to kind of remove some people from participating because they did not get back to providers quick enough in the West Virginia hepatitis academic mentoring partnership. So
yeah, another time sensitive step is a huge thing, and actually, well, there's lots of people using REDCap for lots of things, but another one right here in West Virginia is that Dr. Cohen and Leonard Go at the University of Chicago have worked closely with the Black Lung Clinics group, and they have a national database on Black lung patients. And so the Black lung clinics in the state, funded Black lung clinics in the state, I think there are either 8 or 9, I think it's 8, are participating in a partnership with University of Chicago, the one Black lung clinical excellence center in the country, funded, I think, by Department of Labor. And so the whole thing of training people to do their REDCap database and do the entry was a real heavy lift. And so having the primary care partners actually get those, having somebody whose job it is to get those sleep studies into this in a timely way so that you can see them, is another challenge. Although fortunately, sleep apnea is not a highly time-sensitive condition. It's not like stroke.
right. I mean, a lot of people have had it 5 to 10 years, right?
Yeah. So, but another thing is getting that sleep study into the system so you can see it, and making the questionnaire that people fill out not too long, making it an easy thing, so that if they just answer a few questions, clinical questions, and get that sleep study in there, that's something that is going to take a lot of work. Just like getting people to show up at this echo session and do patient cases, it takes significant kind of recruitment, encouragement, and coaching.
David?
Yeah, I'm really interested in the use of REDCap for this purpose. I didn't know, does REDCap have functionalities where you can, like put data in it and have patients be able to access data and, communicate or providers and be able to communicate back and forth with it?
Mm-hmm. Yep. That's exactly what Dr. Feinberg's program does.
Is that like a customized implementation into REDCap, or is that kind of boiled into the standard REDCap?
It might be customized. I mean, Adam Baus in the Office of Health Services Research, he's the director. He actually and his team kind of make this REDCap database and design it specifically for the project.
Okay, thank you. Yeah, really interesting.
So these were some of the things we were going to hope to pull out of the database. And some of these, Adam said, may be able to even auto-populate. The things that comorbidities we're specifically interested in are COPD, heart failure, AFib, and morbid obesity with a BMI of greater than 40, and then smoking status of known. And then my hope is we'll also be able to obtain the APAP data for people who are treated with auto-titrating positive airway pressure therapy. And then if they go for other treatments, we'll be able to just document at least that they are, following up some way and not falling through the cracks. And so I mentioned this a little bit, but This is Rich, who's executive director of the West Virginia Rural Health Association, who's really going to be helping sort of market this and run this program. Jen's with a West Virginia practice-based research network, and you know, they're going to be supporting our sort of outreach, and they were really, really important in you know, getting us in touch with these rural clinics when we were doing our initial preliminary analysis. Adam Baus, who I mentioned, he's the one who's the database wizard and makes all this happen. Nicole's, as I mentioned, she's at the Cancer Institute. She's really interesting. She's a PhD, but she's a physical therapist by training and does a lot of work in cancer and recovery. Then Dr. Doyle, obviously. I found this picture of you online, Dr. Doyle.
The background is Nicaragua.
Oh, really? Okay.
That's a great picture.
Yeah. So some of the feedback I was kind of hoping to get, you know, on recruiting these providers. I mean, we do have some funds to support a project advisory board who, you know, I think it's going to, you know, we'll be multidisciplinary, and hopefully we'll kind of champion this in the different communities. But does anyone have thoughts on how to best, you know, other ways, you know, and the West Virginia Rural Health Association is really going to help us promote this. But any other sources to tap or things that you guys can think of to really kind of get the word out about this project?
Oh, well, we'll help with the with the Grace Ann Dorney Pulmonary Rehab Centers, our natural group, and which is pretty much overlaps with the whole APHP group. So, you know, but I can't think beyond that. The black lung clinics would be another one.
Okay.
So one, I hate to say this, but, you know, there's a lot of competition between the, you know, healthcare, delivery organizations in the state, right? I mean, so the different systems are in competition with each other. Is there any way to overcome this and make them feel like this isn't an effort for like WVU to grab all the sleep business, you know, in the state? I mean, you know, because in terms of marketing, if you can market it as something that helps all the organizations, you know, then maybe they would buy in.
Yeah.
I mean, that's always the worry when WVU is the center for putting something out is that other organizations will worry it's like a play to get more patients.
Right.
Yeah, that's the times we're living in, David, and so I think I'm kind of live in the Vandalia health world a lot, and actually this has come up for Grace Ann and us just recently to try to cooperate with Summersville Hospital, which is WVU medicine, on coming into the Grace Ann Dorney Pulmonary Rehab Center. So yeah, I don't think it's an absolute. It is just right now, the period we're living in. It's a real significant problem, but I don't think it's impossible. And so I don't have the answer, but I just think this is one more really good effort in which the people promoting it, who are living in both camps, should work together and be creative about how to overcome that, and not give up.
Absolutely, I totally agree. And you know, it's just, you know, this is one of those things where you want to make healthcare better for everybody, you know, and it's not about, you know, business, right? So I'm not quite sure how to package it or promote it or run it in a way that people, you know, don't get into that kind of negative thought pattern.
Well, and Judith said that was very important in the hepatitis program. You know, if there's any sense that the university is trying to make money or steal patients or do anything like that, you know, no one's going to want to participate. Grace Ann?
I don't know. Do you think you could market this through what I hope would be an impartial organization, like the West Virginia Primary Care Association, so that it's endorsed by others that presumably are somewhat above this fray.
Right. Well, I mean, as I said, the West Virginia Rural Health Association is going to be promoting this, and then the West Virginia Practice-Based Research Network is going to be promoting this.
And but what about the primary care doctors organization? Because that's what you need for the referral.
You know, there is no primary, well, I'll start out by saying there is no primary care doctors association per se. I think that the West Virginia chapter of the American Academy of Family Physicians is actually the closest things to a primary care doctors association. Got to remember that, I don't know the exact figures, but probably half of the primary care providers in West Virginia are either nurse practitioners or physician assistants. They really are really carrying the load a lot. So, but with all that, I think a really important ingredient is finding champions, finding primary care champions. And if it's a physician, that's great because they carry a certain amount of social, status and prestige. But there are physician assistants who are, in some cases, many cases, the only providers at a clinical site. So the primary care, and everybody, and almost everybody says they're overworked and too busy, and they've got 1,000 messages in their inbox. So finding a few people who within their organizations are willing to want to work and overcome barriers, both internal barriers and the external barriers we were just talking about. And that's what you've been doing, Rob, and for a while I was in that role. But it's very personal. And so that's why it's so great that you've come out and been at the sites and met people. So trying to think about and recruit primary care and champions, clinical champions, and most of the people who step up to the champion role for a specific project like this already have 6 or 8 other things that they're committed to. It's a paradox that the people who tend to volunteer are not the ones who have sort of capacity, but the ones who probably are beyond capacity already.
Well, and to your point, our focus groups, I think a third to maybe half were actually PAs or NPs.
Yeah, and they tend to have a little less status in their organization and a little less clout. Although some of them are actually the chief medical officers for some of the primary care clinics, like New River, for example, is Angela Barker, who's a physician, a PA. But I mean, you already know who are the people out there that another potential one would be Allison Sela. And there are people out there that I don't know. So that's one of the ingredients, but also what Grace Ann talked about is, finding organizations. And one of them is the AFP, and I think, and they
That's AFP.
The American Academy of Family Physicians has state chapters, and they have once or twice annual meetings too, and getting on their agenda with your kind of core clinical presentation about OSA to them, and then an invitation to be part of this. And
Dan,
yeah, go ahead.
Dan, do you know if there are PA or NP associations that Rob could connect with?
There is a PA association.
Hey, that was my question.
I think they do have meetings.
Yep.
The NPs I don't know about. I mean, I don't know how they get together. And talking about the turf, the turf issues between WVU Medicine and Vandalia Health, and I'm not sure who else. There's also the traditional kind of turf battle between medicine and nursing. But the NPs are a really good bunch to overcome that. I don't think they're as well organized. we would have to figure out how they're organized, because they've been effective lobbying the legislature for prescribing privileges and also independent practice. So they got some kind of organization, but I think it tends to be more one that deals with the legislature.
I know at the national level, there's an American Association of Nurse Practitioners that's very, very activist.
Yeah.
Okay. And I guess anyone on the call, what do you guys think about this sleep testing in rural clinics? One thought we had is people who complete the training, we see if we can get testing devices for them to have in clinic to disperse versus, I think what happens mostly now is they go to these sort of national companies like Virtuox who, will send the device in the mail to the patient, and then the patient sends it back and they download it.
Well, some of the sites are doing sleep testing and are figuring out how to make money on it, so that and Boone Memorial Hospital is a good example of that.
Okay.
In Boone County. So some of them have seen it as a business opportunity and have developed it, but they're doing, I think, more in-hospital sort of sleep lab. I mean, they've created sleep labs, and I think they're doing it that way.
Okay.
So
You
I
do,
think-
you do get sort of a facility fee for even setting someone up with a home sleep test. So there is potential to make money on it, even if you're not the one doing the interpretation.
So if you really if you were really wanting to push this, which this bullet doesn't sound like you're so sure about that, it would be coming up with like a sort of a little business plan that the RT could take to her hospital CEO and show it to them, and use it, and generally you use that as a basis for another part-time person or another full-time person in your department. So anyway, I think you'd need a business plan for this to show them, and then to show their CEO, and in it there would be there'd need to be at least this many patients a year, but it does seem possible. It's pretty easy though, as you say, to just contact one of the companies, and like when we have done these studies on ourselves at home, that's how we've done it.
Okay.
I guess one thought I had is what you mean by sleep testing, because, there's a lot of, screening versus more detailed versus, so the more screening to the screening side it is, the easier it is to implement, in primary care.
Right.
Right. Any problems you guys see with the REDCap database? I mean, Judith has seemed to have Dr. Feinberg seemed to have a lot of success, getting the providers to utilize this database. Her only feedback was, you got to keep it as straightforward, as simple as possible. You can't have them filling out 100 different data points. You just gotta pick what's the most clinically relevant and go with that.
Well, there will be problems, but and what she just said is exactly what I found with the Chicago-based Center of Excellence Black Lung REDCap reporting. It probably took more than 5 years to get it really functional, because it took a lot of training and a lot of encouragement, and the Black Lung Clinics organization took that on and championed it and made sure it happened. Like Susie Chris was one of the leaders of that. So there will be problems, but I think it's feasible and a really good tool. The hard part is finding the people who really learn it and use it often enough that they don't have to teach themselves all over again each time they do it.
Okay.
The other issue is, do all your clinics that you want to hit have good broadband access?
They mostly do, because they depend on their EHR, David, and the links in their EHR. So I think the answer is mostly they've figured it out, yes. Not their patients, but the clinics themselves, yes.
That's good to hear. Thank you.
And then the only other, question I had is, you guys have any ideas for some other funding sources? We actually did get some NIH funding for this, which is going to help pay for Adam developing the database to an extent. And then, we're going to give some money to the West Virginia Rural Health Association, but in Judith's model, she does sort of pay speakers. She also pays for any participants get CME. Dan, do you think the CME part's absolutely essential for people to participate?
You mean in CME that is authorized for certified for credits for them?
Yeah, right.
It's a really good thing to have, and you've got the resources, to get multiple different bodies to approve it, like something for the nurses, something for the RTs, something for the PAs. Well, the PAs and the physicians are the same, so it's really good to have.
Okay.
Is it absolutely essential? Probably not for a motivated champion, but for the people that are kind of on the fence, I think it's really good to have.
Okay. Yeah, so I actually just wrote a proposal to ASM, so hopefully they'll be interested in this. But I think at least we have the money to get this initiated. So
Has Dr. Feinberg written up her experience with the hepatitis program at all?
they just did. I believe it's submitted now. Adam Baus has written up their red cap experience,
Uh-huh.
but Judith's putting together a paper right now on her hepatitis program.
So if you could do another slide with links to those articles when they exist, that would be really good.
Okay.
Because
I could probably, let me see here. I just included this for Grace Ann because she said she missed me at ATS this year.
they probably missed her.
Oh, I was there. I thought you were presenting on the Best of ATS today. And yes, I was there and I presented, but I didn't see you.
Yeah. That's
Hey,
what that picture.
Rob, also on your team member slide, put the names on it.
Yeah.
Because you know them, but we don't know all of them. I know only one I know is Adam and me.
What was
I
that?
had another
let me,
funding
show you
suggestion.
this real quick.
I had another funding thought, Rob,
Uh-huh.
which is WVCTSI when it comes up for renewal again, because it comes up for renewal every 5 years.
Yeah, they just got renewed actually.
Oh, that's too bad, because this would be a great project under that.
Yeah.
Okay.
So this is, can you guys see my screen
I
with
do.
the
Yes.
West Virginia ham? So this, has all the information on how it works. And like I said, our program is really based on this program. And I think they had links to Adam's paper on here, but might be making that up. But I'm sure I have it somewhere. It's not on here. But they've really had a lot of success. They have a cure rate of 98%. So it's trained 177 individuals. And that's sort of the spread of where all the different, experts who've been trained reside at the county level. So
Interesting. Great. I'm texting Adam right now, asking him to send us a link to that.
any final thoughts or suggestions you guys have? Dan, I'll definitely be in touch.
Really
Yeah.
fascinating stuff.
Yeah.
It's great effort.
When I think about all the work you've been doing on OSA, Rob, in some ways OSA is such an interesting condition because you've gathered all the evidence about its link to its association with, and I'm not sure about, the causation link, but its strong association with so many important chronic diseases that we talk about all the time, that it's almost like the canary in the mines, and he'll help me out with what's the technical term. It's kind of like a sentinel condition, and it's not so much an end stage disease. I mean, it's almost more like an intermediate stage of getting a really life-shortening disease.
Right. And that's why I really think I almost think of it more as, back to this slide, that more upstream from what we typically intervene on. And it trickles down into, metabolic health, cardiovascular disease, respiratory disease, mental health. It really has broad implications.
Yeah, but it doesn't fit in a neat chronic disease. At least it hasn't yet achieved the status, the social status and cultural status, either in medicine or in society at large, that say diabetes or asthma or
Right.
A myocardial, heart attack, hypertension. It hasn't achieved that recognition and status yet, and I'm not sure you want it to, in a way. Just like obesity is thought of not so much as a disease. I mean, people try to put it into a disease model, but it's more of, and risk factor seems too weak a label. But it's, in that respect, I think it's really interesting to try to figure out how to frame it, how to explain it, and how to intervene with it. And I think the project you're doing is a great experiment in that. And I definitely will think about it and look for potential champions. And as I said earlier, the problem is that all the potential champions are already championing other things and are getting grabbed by people to come into their program and be their champion. But still, there are young people coming up. There's new people coming up in all three of really all four of the categories of physician, primary care physician, nurse practitioner, PA, and respiratory therapist. And probably the most important category I'm leaving out is the CEO of a primary care, either hospital or health center or private practice, who's interested in more than spreadsheets and money, and is able to keep his or her organization financially afloat, but also takes a direct interest in clinical pathways. And there are a few people like that. I mean, Craig Robinson historically has been one of those at Cabin Creek. And so they too, because they have the power to recruit their physicians. So finding those people is really important, and I'll try to keep working on that. And we can do that. And another thing is we have quarterly meetings of the Grace Ann Dorney Pulmonary Rehab Centers, and respiratory therapists tend to show up for those. So it would be good, and there are a few of them I think you might not have met already. It would be good for you to come and do like a probably 20-minute explanation of and cramming in the epidemiologic footprint and importance of OSA, and then talking about this project and inviting people to be part of it.
Okay, great.
Thank you all so much. This has been really great discussion, and I'm so happy you all were able to hop on as well. And really,
And sorry for changing at the last minute, but I really wanted to get everyone's feedback on this as a moving forward.
No, it's great having that discussion, and like you said, the feedback is always so helpful. And we can always schedule for the Best of ATS the next time as well, maybe the spring of 2023 or 2024. Wow. So, no, we appreciate you, Dr. Stansbury. Thank you so much for that. Any final comments, questions from the group? We still do have 4 minutes, so I hate to cut it short if there's
Wow,
more.
that time has flown. Yeah, I just wanted to mention what was it? There was somebody who I wanted to get him to do a presentation to the Echo. What was it? Mitra and Elizabeth, that I sent you that email?
Great. Yes, you had emailed us. So I'll be on maternity leave actually during the time we do curriculum development for next spring. But Elizabeth and I will talk about it in our team meeting, and we'll get back to you, Dr. Doyle. I think that'd be great having them scheduled.
Do either of you remember who? I'm forgetting who or what it was.
Yes, let me take a look at this real quick.
It seemed really, really relevant at the time I sent the email.